Fluid and electrolyte management in the intensive care unit is crucial for patient stability. Advanced strategies involve precise monitoring of fluid balance, electrolytes like sodium, potassium, and calcium, and understanding their impact on organ function. Tailoring interventions to individual patient needs ensures optimal outcomes, reducing complications and improving recovery rates. Advanced fluid and electrolyte management in the intensive care unit is crucial for patient outcomes. Understanding the nuances of fluid types, such as crystalloids and colloids, and their clinical applications is essential. Mastering these strategies ensures effective resuscitation and supports evidence-based practices in managing sepsis and shock, while maintaining fluid stewardship principles. Differentiate fluid types for clinical applications, mastering crystalloids, colloids, and blood products for optimal resuscitation. Understand evidence-based strategies for fluid resuscitation, applying guidelines for sepsis and shock management. Recognize intensive care unit electrolyte disturbances, identifying critical imbalances needing intervention. Highlight the pharmacist's role in monitoring, correction, and defining responsibilities in electrolyte replacement and safety protocols. Crystalloids, such as lactated ringers and plasmalyte A, are first-line intravenous fluids, preferred over normal saline due to reduced hypochloremic acidosis risk. Colloids like albumin are reserved for specific conditions like hepatic failure. Avoid hydroxyethyl starch due to acute kidney injury risk. Blood products, including packed red blood cells and fresh frozen plasma, are crucial for managing hemorrhagic shock and coagulopathy. In sepsis or shock, administer 30 milliliters per kilogram crystalloids within 3 hours, favoring balanced solutions for better outcomes. Avoid fluid overload to reduce mortality, acute respiratory distress syndrome, and kidney injury risks. Transition from resuscitation to de-escalation is crucial. Fluid stewardship is vital, akin to antimicrobial stewardship, in preventing intensive care unit complications. Hyponatremia requires fluid restriction for mild cases, while severe cases need hypertonic saline with careful monitoring. Ensure correction rates stay below 10 milliequivalents per liter per 24 hours to avoid osmotic demyelination. For hyponatremia, replace free water, correcting deficits slowly at the same rate. Regularly monitor sodium levels and conduct neurological assessments to ensure patient safety. Hypokalemia, defined as potassium levels below 3.5 millimoles per liter, requires oral or intravenous potassium chloride replacement, prioritizing magnesium correction. Monitor cardiac rhythm and renal function closely. Hyperkalemia, with levels above 5.5 millimoles per liter, necessitates calcium gluconate for cardiac protection, insulin with glucose, and beta-2 agonists to shift potassium, and diuretics or dialysis for removal in severe cases. Hypomagnesemia, prevalent in intensive care unit patients, leads to refractory arrhythmias and muscle weakness. Rapid correction with intravenous magnesium sulfate is essential. Hypomagnesemia, though rare, requires intravenous calcium and possibly dialysis for severe respiratory depression. Hypercalcemia demands intravenous calcium gluconate or chloride, monitoring QT prolongation. Hypercalcemia management includes intravenous fluids, bisphosphonates, and calcitonin for quick relief. Hyperphosphatemia is prevalent in sepsis and refeeding syndrome, requiring intravenous or oral phosphate replacement depending on severity and gastrointestinal function. Hyperphosphatemia, often linked to renal failure, is managed by dietary phosphate restriction, phosphate binders, and possibly dialysis. Phosphate imbalances critically affect cellular energy metabolism and bone mineralization in critically ill patients. Pharmacists play a critical role in fluid management by optimizing crystalloid selection to prevent chloride overload, adjusting electrolyte doses for renal and hepatic dysfunction, and monitoring for rapid correction risks like osmotic demyelination. They assess intravenous compatibility with concurrent medications and lead intensive care unit team education on evidence-based fluid stewardship, ensuring safe and effective patient care.